Hello, my name's Dr. Nick Swale. I'm a GP and an expert witness in the field of GP clinical negligence. This is a short presentation about peripheral arterial disease, or PAD for short, looking at what learning can be gained from clinical negligence claims with the aim of preventing such claims from occurring. This presentation is aimed at any primary care clinician who assesses and manages patients, including GPs, advanced nurse practitioners and physician associates. For brevity, I'm just going to refer to GPs. So, why this presentation? There are four reasons. Firstly, because peripheral arterial disease is common in primary care clinical negligence claims. Secondly, because in my experience, unfortunately, a significant proportion of PAD claims have identifiable aspects of inadequate care that contributed to an adverse outcome. Thirdly, because it is my strong belief that this inadequate care could often have been easily avoided, meaning that many such claims could potentially have been prevented. And finally, because in my experience, there is currently very little dissemination of learning from claims to primary care clinicians. It is my strong belief that learning from claims can significantly help to improve safety and reduce the risk of future claims, with benefits to the patient, the individual clinician, and the NHS as a whole. So, first of all, some definitions. PAD can be categorised as intermittent claudication, critical limb ischemia, also known as chronic limb-threatening ischemia, or acute limb ischemia. And in more detail, intermittent claudication, or IC, typically causes exertional pain in the legs that is relieved by rest. Critical limb ischemia, or CLI, occurs when arterial supply is so severely impaired that there is an imminent risk of limb loss. However, the term CLI is now being replaced by the concept of chronic limb-threatening ischemia, or CLTI, which is characterised by chronic inadequate tissue perfusion in combination with ischemic rest pain, with or without tissue loss, for example, ulcers, gangrene or tissue necrosis, and with or without infection. CLTI represents the end stage of peripheral arterial disease when there is threatened limb viability. And lastly, acute limb ischemia, or ALI, when there is a sudden decrease in limb perfusion that threatens limb viability. It's worth noting that ALI can be due to an embolus or thrombosis. Another way to think about the various subgroups of PAD from a primary care perspective is by the urgency of action that is needed. So there can be routine situations, and this covers intermittent claudication. There can be urgent situations, this covers critical limb ischemia and chronic limb-threatening ischemia. And then there can be emergency situations, and this covers acute limb ischemia. It's also worth mentioning that whilst PAD usually occurs in the legs, it may occur in the arms. So, now I want to look at what goes wrong and what we as primary care clinicians can learn from this. In my experience, PAD claims are relatively common, particularly for ALI, which appears to be relatively easily missed. In terms of what goes wrong, I'm going to look at 5 areas. So firstly, a failure to consider PAD. Secondly, a failure to assess for PAD. Thirdly, a failure to recognise red flags of PAD. Fourthly, a failure to manage suspected PAD. And fifthly, a failure to safety net. So, firstly, failure to consider PAD. This is a very common occurrence in clinical negligence claims and occurs when a patient presents with PAD, but the GP simply does not consider PAD within a differential diagnosis. In my experience, it is most likely to happen with ALI. So when should we consider PAD? Well, NICE states that we should assess people for PAD if patients have symptoms suggestive of PAD, or have non-healing wounds on the legs or feet, or unexplained leg pain, particularly in patients with diabetes. NICE states that we should also assess for PAD for patients who are being considered for interventions to the leg or foot, but this isn't particularly relevant to primary care, or are being considered for compression hosiery, which is very common in primary care. And in detail, the features of PAD are, firstly, for intermittent claudication, there can be symptoms of exertional leg pain, fatigue, cramping or weakness, which usually occurs after a predictable distance and is relieved by rest. Symptoms of distal before proximal, for example, the lower leg is affected before the upper leg, and there's no rest or night pain, and no features of CLTI or ALI. Secondly, the features of chronic limb-threatening ischemia. There may be symptoms of persistent rest pain or night pain, worse with elevation. For example, patients may sleep with their leg hanging out of the bed. There may be colour change, such as redness, cyanosis, or pallor on elevation. And there may be skin changes, including non-healing foot wounds, ischemic ulcers, tissue loss, and gangrene or tissue necrosis causing black areas on the skin of the leg. There may be absent foot pulses. However, it's worth noting that foot pulses may be palpable if the toes only are affected by ischemia. And thirdly, the features of acute limb ischemia are the classic 6 Ps, which are pain, pulselessness, pallor or cyanosis or mottling, perishing cold, also known as poikilothermia, paresthesia or numbness, and power loss or paralysis. And note that in ALI, not all 6P features may be present. ALI symptoms can be further classified as that due to an embolus or that due to a thrombosis, and ALI due to an embolus, the onset is acute within hours or so, and the limb appears mottled and there may be a distinct demarcation between areas of perfusion and ischemia. A vascular examination of the other leg may be normal, and ALI due to embolus may present entirely anew with no past symptoms of PAD at all. Whereas ALI due to thrombosis, the onset is more gradual within days to a couple of weeks or so, and the leg may be bluish with no distinct demarcation, and the presentation may be with worsening claudication, and pulses in the other leg may also be abnormal due to pre-existing PAD. A useful tip to prevent missing PAD or other diagnosis is the 3D approach, which is to make a conscious effort to think of 3 differential diagnoses in any diagnostic situation. This is useful if the diagnosis is unclear, but also if the diagnosis seems obvious, as we as humans are very susceptible to cognitive bias that can block us from considering differentials. For example, if a patient presents with leg pain and neurological symptoms, it may appear to a GP that the obvious diagnosis is sciatica. If ALI is not considered at all, other clinical features may be ignored or not assessed for. However, with a 3D approach, symptoms of leg pain and numbness might lead to a conscious consideration for sciatica, ALI or neuropathy, and each condition would be considered and then assessed for, and therefore much less likely to be missed. So next we're going to look at a failure to assess. An assessment covers history, examination and primary care investigations, which would usually be blood tests and Doppler ultrasound scanning to measure the ankle brachial pressure index. Again, this aspect is a very common occurrence in primary care negligence claims. Once PAD is considered within a differential, it is necessary to assess in general and with some specific considerations. When assessing the history, it's important to assess the site of pain, the duration, the nature of the pain, exacerbating and relieving factors such as exertion, associated symptoms such as neurological symptoms, ulcers or colour change, progression, risk factors such as smoking and diabetes, and past history. The pain assessment mnemonics such as Socrates are useful. A vascular examination should include at least the colour and temperature of the limb, an assessment for any wounds and the pulses, and this should include at least an assessment of the foot pulses, dorsalis pedis and posterior tibial, but consider also checking the popliteal and femoral arteries and the aorta. There should be an assessment of the capillary refill time. Primary care investigation may be necessary unless immediate referral is required, and investigations would usually need to include ABPI testing, and for intermittent claudication, it's usually necessary to check blood pressure and blood tests, including cholesterol and HbA1c. A further comment to make is that in primary care, like most conditions, PAD diagnoses or exclusions of diagnoses are usually working rather than definitive, as they are based on a level of suspicion for or against that diagnosis. For PAD, like most conditions, the level of suspicion will depend primarily on the clinical features. It follows that a failure to adequately assess will increase the likelihood of missing a diagnosis. The next problem that can occur is a failure to recognise PAD alarm features or red flags. The red flags for CLTI and ALI are essentially the clinical features which we've discussed just now. Again, this is a relatively common problem that occurs in primary care negligence claims, particularly with ALI. Next, there can be a failure to manage PAD in primary care. Again, this can be categorised by the various presentations, i.e. a failure to manage IC, CLTI or ALI. Primary care negligence claims usually involve failures to manage CLTI or ALI, and the most common problem is a failure to refer with adequate urgency, which may result in avoidable amputation. Again, this is a common issue in clinical negligence claims. Suspected CLTI should result in an urgent referral, whereas suspected ALI is a medical emergency and should result in an immediate referral. Finally, there can be a failure to provide adequate safety netting advice. A failure to provide safety netting advice could result in the patient not re-attending in time, leading to a worse outcome. Again, this is a common issue in clinical negligence claims. Safety netting advice can be general or specific. General advice might be simply to advise the patient to return if they were no better or if they got worse. Specific advice might be to warn the patient about the symptoms of CLTI, for example, rest or night pain, or ALI, i.e. to warn the patient about the 6 Ps. Now, I would say that at least general safety netting advice should be provided. It can be useful to provide this in writing, which could be by text, for example, using AccuRx, etc. It's very easy to produce pre-written safety netting text, which takes seconds to send. Another method is providing a patient information leaflet. This could be a hard copy printed off and given to the patient or sent by text, for example, the NHS website info or patient.co.uk information leaflets. And lastly, I'd just like to mention the guidance I've referred to, which in this case are the NICE clinical knowledge summaries and the NICE clinical guideline 147 on peripheral arterial disease. So, in summary, it's my strong belief that primary care clinicians can reduce the risk of missing PAD and getting into legal trouble. Based on my experience, I think there are 5 main ways to do this. Firstly, by considering PAD as a differential diagnosis when appropriate. Secondly, by having a good understanding of the red flags and the guidance. Thirdly, by developing consistent and competent assessments. Fourthly, by referring with appropriate urgency when needed. And fifthly, by providing good quality safety netting advice. I think that all of these steps can be done easily without needing significant additional time or resources. And the benefits are significant to the patient, the individual clinician, and the NHS as a whole. Thank you for listening.